Welcome to This Week in Oncology. This week, we're covering 5 notable papers spanning biomarker-driven immunotherapy, cellular therapy in gastrointestinal malignancy, antibody-drug conjugate mechanisms, and management of opportunistic fungal infections in oncology. Let's dive in. Beginning with biomarker-driven strategies in breast and gynecologic oncology, investigators publishing in Clinical Cancer Research evaluated the prognostic and predictive value of tumor-infiltrating lymphocytes, or TILs, for adjuvant immunotherapy in high-risk early triple-negative breast cancer. The Phase 3 BRAVE trial randomized 466 patients to adjuvant avelumab or observation following standard therapy. Findings revealed that higher baseline TILs were independently associated with improved disease-free, distant disease-free, and overall survival across the entire cohort. Notably, avelumab improved outcomes exclusively for patients with baseline TILs of 30% or higher, particularly in patients with residual disease after neoadjuvant chemotherapy, where 3-year distant disease-free survival rates reached 92% with avelumab compared to 58.7% in the control arm. In contrast, patients with low baseline TILs derived no significant benefit from the immunotherapy. Shifting to antibody-drug conjugates in cervical cancer, another study in Clinical Cancer Research explored the molecular mechanisms underlying the clinical activity of tisotumab vedotin in patients with recurrent or metastatic disease from the INNOVA-TV204 trial. While tissue factor expression is required for drug binding, clinical responses were previously noted to be independent of exact tissue factor levels. Gene expression profiling demonstrated that higher expression of gene signatures linked to natural killer cells and myeloid cells was significantly associated with improved clinical outcomes. In vitro assays confirmed that tisotumab vedotin induces tumor cell death through myeloid-mediated antibody-dependent cellular phagocytosis and natural killer-mediated cellular cytotoxicity across various tissue factor expression levels, highlighting a multimodal mechanism of action that relies heavily on immune effector pathways. Advancing to cellular and targeted therapies in gastrointestinal malignancies, a Phase 1 trial published in Clinical Cancer Research assessed non-armored, nanobody-derived guanylyl cyclase C-targeted CAR T cells in 24 heavily pretreated patients with metastatic colorectal cancer. All patients experienced grade 3 or higher hematologic toxicity, and 75% developed cytokine release syndrome, both of which were generally manageable. 2 treatment-related deaths occurred, including one from immune effector cell-associated hemophagocytic lymphohistiocytosis-like syndrome, and one from an intestinal fistula following rapid tumor regression. The overall response rate reached 33%, with a disease control rate of 63%, a median progression-free survival of 57 days, and a median overall survival of 190 days. Higher in vivo CAR T expansion directly correlated with better disease control, establishing clinical proof of concept for guanylyl cyclase C as a therapeutic target, while underscoring substantial toxicity challenges. Finally, addressing infectious complications in immunocompromised cancer patients, Annals of Internal Medicine published a Phase 2b trial evaluating olorofim, a novel dihydrorotate dehydrogenase inhibitor, in 41 patients with poorly controlled disseminated coccidioidomycosis who lacked alternative treatment options. Central nervous system disease was present in over 70% of patients. Clinical success, as adjudicated by an independent data review committee, was achieved in 75.6% of patients at day 42 and 73.2% at day 84. The primary treatment-emergent adverse event was hepatic biochemistry elevation, affecting roughly 22% of patients, which was successfully managed with monitoring, dose reductions, or pauses in most cases, establishing olorofim as a promising therapeutic option for treatment-refractory disseminated disease. If you only have time for one paper this week, make it the BRAVE trial analysis on tumor-infiltrating lymphocytes and avelumab efficacy in triple-negative breast cancer. It provides actionable, biomarker-driven data that directly guides patient selection for adjuvant immunotherapy. Here are the key takeaways from This Week in Oncology. Baseline and residual tumor-infiltrating lymphocytes strongly predict benefit from adjuvant avelumab in high-risk early triple-negative breast cancer, limiting efficacy to patients with high TIL thresholds. Tisotumab vedotin exerts its clinical activity in cervical cancer through multimodal mechanisms involving both direct cytotoxicity and immune effector pathways mediated by natural killer and myeloid cells. Non-armored guanylyl cyclase C-targeted CAR T cells show encouraging initial efficacy in heavily pretreated metastatic colorectal cancer, though manageable, but significant toxicities remain a major barrier. Olaravimin demonstrates high rates of clinical success in patients with poorly controlled disseminated coccidioidomycosis and limited alternative treatment options. That's your roundup for this week in oncology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. One more note before you go. Only 4 new papers of note met the bar since the last update. A quieter stretch for new literature. Still worth revisiting from recent updates. Systemic treatment of ovarian cancer recurrence. ASCO Living Guideline. Version 2026.1.0 in Journal of Clinical Oncology. And switching to camizestrant at ESR1, mutation emergence before disease progression, during first-line treatment of hormone receptor-positive advanced breast cancer. Serena 6. Extended analysis of a double-blind, placebo-controlled, randomized, Phase 3 trial in The Lancet Oncology. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.